Hello everyone, this is the first video for CRS. In this video, I'm going to be doing only cardiology and I'm going to be doing the IEA questions. A couple of announcements before we start. Number one, like this video and subscribe to the channel. Uh, if you go to the playlists under the channel, you can see the different question banks for different modules. I'm going to try to make a video like this for all the question banks I can find. Announcement number two is that I'm going to put an email down in the description. If you have any inquiries, if you want to give me any ideas, if you want to correct something within the video, feel free to contact me there. Okay. This is the first video. It's going to be multiple parts. Uh, and each video is going to be about 30 minutes. I'm going to start my timer. All right. So let's get started. I'm going to skip the kidney questions. Okay. So question number one is talking about a 40-year-old guy. Right-sided flank pain for the past 3 days, right? Has history of hypertension for 10 years, kidney stones or nephrolithiasis, right? Physical examination shows CVA. Well, it looks like it's a kidney question. We're going to do it anyways, right? Coastal vertebral angle tenderness on the right, okay? So summarize it so far. Guy has hypertension, and kidney stones, now has pain on the kidney on the right. Abdominal ultrasound shows bilateral renal cysts, right? So two things become important. One, this guy isn't a kid and he has bilateral renal cysts. You already know when you have bilateral renal cysts, two possible things can be your answer. It's the autosomal dominant kidney disease, the polycystic kidney disease, or the autosomal recessive. Uh, that this one, the autosomal recessive one, happens in children. But we're talking about this one, the autosomal dominant one that happens in adults. One way you can think of it is that autosomal recessive, it means the person is lacking both alleles. That's why it's a more severe form that you see it in children. You can also, it causes oligohydramnios because it happens, if it happens in the fetus isn't producing enough urine and you get oligohydramnios, right? Now the question is asking us, what's the most following um, kind of like consequence of this? So polycystic kidney disease, the gene is this thing, right? It's autosomal dominant. It happens in adults. Basically, what happens is that your kidneys aren't working properly and they get really big. So you can see them on ultrasound. When your kidneys aren't working properly, they become ischemic. When they become ischemic, they kind of signal to the heart and to the cardiovascular system to, hey, start pumping harder. The kidneys aren't getting enough blood, and the kidneys are important organs, so that your body starts to compensate for that. That results into hypertension. Then the hypertension results into a bunch of problems. But one that's very significant for this is berry aneurysms, right? So um, you get berry aneurysms because you have hypertension. Think of something else that also causes berry aneurysms. Well, first of all, what are berry aneurysms? You know, an aneurysm is like when you have like a part of the vessel that gets big. Berry aneurysm is like same idea, but like kind of grow like sticks out like this, and blood is getting injected into here, right? That's the idea. Now, the other thing that could cause berry aneurysm is like coarctation of the aorta. That's like seen in something like Turner's, and like aorta is coming off your heart like this, and if there's a coarctation here, it means blood is gonna. And these are the three vessels that get off the aorta here. Blood is gonna have higher blood pressure here. It's gonna go up to these three vessels with higher pressure. One of these vessels is gonna be your carotids, and that causes high blood pressure in the brain, leading to berry aneurysms in the brain. So that's another thing, the coarctation of aorta that's associated with Turner syndrome. Okay. With polycystic kidney disease, the other thing you can see is the way I think Pathoma describes it as is that you have cysts everywhere. You have cysts in your kidneys. You also have cysts in your livers and like everywhere else. but you can also think of the berry aneurysms as kind of like cysts in the brain. But now you remember why it happens. It's because of the hypertension, right? And I think the why behind why things are the way they are is really what helps it stick for me. Uh, Aortic stenosis, again, it's not isn't really caused by this, but it can also uh, well, no, it's not really related to this condition at all. It just means the aortic valve is stenosed. Uh, Pneumothorax, no. Bitemporal heminopsia. This is what happens when you have like a tumor in your um, pituitary, right? If you remember this from FDM, not from FDM, from MB. Renal cell carcinoma is like within this module. It's also known as clear cell carcinoma. It One important thing to remember about it is that it metastasizes hematogenously, even though it's a carcinoma, and carcinomas usually metastasize lymphogenously or lymphatically. This renal cell carcinoma is one of the few carcinomas that likes to metastasize hematogenously. It metastasizes often to the renal vein and from there to your lungs, right? Uh, One other important thing is that it's associated with, it has a famous mutation associated with it. But I can't remember what it is now. We're not doing. It starts with a V. I can tell you that. It's von Whipple something. Von Whipple sounds like that. All right, then yeah, very aneurysm. All right, so the other point I want to mention is that I haven't seen the answer to these questions, so I might get a lot of them or some of them wrong. All right, so this is again not a cardio problem, but we're gonna attempt it anyways. Uh, so this guy has blood in his urine, right? Uh, the only and then you can see a well circumcised mass within the bladder, right? So, I mean, judging from the choices, this is gonna be like a parasite question, right? Let's go. Let's explain what each one of these things are. Um, this thing is oh, what's it called? It's a cestode, and it causes B12 deficiency, right? Um, that's what there is to know about it. Uh, this is amoeba that like goes to the brain, right? And then you got three schistosomas, right? So I think it's D. Yeah. So the one that causes bladder cancer is D. Uh, you just gotta know this, but basically it invades your bladder, it irritates it for years, and any irritation of the bladder. Okay, this is important. Physical irritation of the bladder causes squamous cell carcinoma of the bladder. Okay, squamous. Again, just like all squamous cell carcinomas, is associated with the pearls, the creatine pearls, and the bridges or whatnot. And this is something that's, when you see it in the context of a guy who's a fisherman, who's like at risk of getting a parasite, this is a parasite you want to think of, right? Um, yeah. And okay, so I'm gonna give you an extra point. So remember from module whatever, 1 or 2 or whatever, from embryology, if this is your bladder, remember the urachus that's like connects the, so this is the bladder, right? This is like the urethra exiting, this is front, this is back, this is the pubic symphysis, and this is your belly button up here. Remember the urachus that was like a structure that like connected the belly button to the bladder, and as you like grow up or as you're born, going through embryogenesis, this like tube over here closes, right? So for some people, this tube doesn't completely close, and it's like on the end, it has like a little pouch that joins the bladder, right? And if you have this pouch, you're at risk of adenocarcinoma of the bladder, right? So you know about two types of carcinoma so far: the squamous, that is physical irritation, be it like parasite or whatever. Um, and you have, about adenocarcinoma. There's also the transitional type, right? The transitional type is the main type. It's the one that like just like it's the actual carcinoma of the normal epithelium of the bladder. Okay. Uh, this seems to be a renal question. Okay. Now these two genes, we mentioned it before. This is the adult polycystic kidney disease. This is the child one, right? The, I guess, like younger guy. And this one is autosomal recessive. This one is autosomal dominant. Don't get tricked by D and dominant. That's not how it works. Just remember, I mean, polycystic kidney disease. I don't know what the H here is stands for. I just know the one has an H is for children. Okay. Now let's see. 48-year-old woman, flank pain, bloody urine. Okay. Hypertension. So her father had similar symptoms and a cerebral hemorrhage, right? So automatically makes me think of polycystic kidney disease, especially after seeing these choices. Large cysts in both kidneys. Okay. Easy. Don't even trip, dog. Okay, 5-year-old brought to the ER. There's sugar in her urine. Okay, it's a kidney question. Really shouldn't attempt these because I'm a little rusty on kidney. I don't want to get stuff wrong here. But if I started, this is the rule. If I start, I have to finish it. She's treated with for impetigo 3 weeks ago. Okay, good. So impetigo usually, well, first of all, let's talk about what it is. It's a surface infection, as opposed like it's a infection with bacteria. The bacteria is usually group A strep or Staph aureus, right? It's bolus or non-bolus. The non-bolus type is usually group A strep, and the bolus type is usually Staph aureus, right? Uh, non-B and then B. Okay. Uh, so this one is trying to make it related to kidney, so it's probably group A strep, and it's about group A strep, glomerulonephritis. Um, okay, and it's asking you why. Why are we seeing this, right? So group A strep, it has this protein called the M protein, right? M, it looks like the mycin on the heart muscles, right? And then we have this thing. So we have an autoimmune reaction to the heart. That's how the heart problem. That's how rheumatic fever works. The When it comes to the glomerulonephritis, it's a different story. The story is the story of immune complexes. Basically, the antibodies make immune complexes, and then they deposit onto the kidney. That's how it works, right? So antibody two basement membrane, right? This is talking about good pastures, right? And antibody 2M protein, that's our autoimmune, uh, endocarditis, myocarditis, stuff that happens with rheumatic fever. Food processes, it's really minimal change disease. This is not it. Glycosylation of tubules is diabetes. Maybe. I don't know for sure. It's A. It's D. Okay, well, I told you I shouldn't try these questions. So D is actually the IgA nephropathy, right? So remember I said the IgM, right? It makes immune complexes. That's the IgM antibody that makes immune complexes. The IgA, so the IgA the Ig, sorry, the antibody that's anti protein M, right? It doesn't attack the kidney directly. It makes immune complexes, right? This is an immune complex, and this kind of precipitates in the glomeruli and blocks it. I really shouldn't attempt the kidney questions because I've done a bunch of cardio and now I'm doing all the cardio questions. This is like after term four for me, so I've seen all these and like finished them. And so I've just done a cardio review. I'm like fresh on cardio and like I'm doing cardio questions. If like when I do a renal questions, I it's really I'm pretty rusty at it. Besides, these have like mistakes in them too. So I really shouldn't try these questions because even if they're wrong, let's say if this was a wrong answer, I wouldn't know a lot to like be able to like correct it. So I'm gonna do my best to skip the kidney questions. This is kidney. All right, this sounds like kidney again. Kidney, 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 kidney. Okay, this sounds like right up our alley. 35-year-old guy's got headache and diaphoresis, miliary thyroid cancer for 3 years. Oh, this is a men question. I'm gonna explain it. Uh, Anxious, definitely middle age, super high blood pressure, and so VMA is high. So it's a pheochromocytoma. But you might be thinking, why pheochromocytoma plus medullary thyroid cancer? So this is a men question. Men stands for multi-endocrine neoplasias, and it has men 1, men 2, 2A, and men 2B. It has three subtypes, right? So the way I remember this is that men 1 has 3 P's, men 2 has 2 P's, men 3 has 1 P. Okay? So first P is pheochromocytoma. Okay? And then we got pituitary tumors, right? And we got pancreatic tumors. Now, for these guys have two M's. They have, when they don't have a P, they have an M, right? So the M is medullary thyroid cancer. This guy also has medullary thyroid cancer. Okay. Uh, they all have, so, okay. Now this guy also has a morphanoid. So these guys are tall, thin fingers. These guys also have mucosal neuromas, right? These guys have parathyroid tumors. Parathyroid, hmm. And then you got pheochromocytoma here, right? Something like this, okay? Uh, so the reason you're gonna learn more about this in theirs, But the reason you basically get this pattern of two things happening is because this guy has probably meant to A, and that's your answer. So what's gonna happen because of this meant to A? So you get this super high blood pressure. What does that mean? Malignant hypertension, HTN, hypertension, malignant hypertension. When you have blood pressures that are super high, you have a characteristic way of damaging the vessels, and um, there's two ways that this has been described, like, from a pathology perspective. One of them is this, a fibrinoid necrosis of the afferent arterioles, just like a fibrinoid necrosis, right? Let's go through them and like say what they are. Cystic dilation of the collecting tubule. Cystic dilation of collecting tubule is a polycystic kidney disease thing, right? Right. This is important. The dilations is what leads to the cysts. Platelet fibrin thrombi in the I don't really know what this is trying to say. The thrombi in the glomerular capillary. Oh, maybe this is something like a HUS, or like any sort of macroangiopathic hemolytic anemia, right? Okay, so this is it. Hyperplastic arterial. So remember I said there's two ways that high blood pressure is described on pathology. This is the second way. Hyperplastic arterial, basically arteriosclerosis of the afferent artery. So hyperplastic, the way it looks like an onion skin, something like this. Uh, Fibrin necrosis is also associated with malignant hypertension. So I'm not like comfortable really between these two, but I think I'm leaning more towards D. But it could really be either because they're both described as um, ways that high blood pressure, super high blood pressure that goes into malignant territory can cause damage on the vasculature. Splitting of the lamination of the basement membrane. This sounds like a kidney thing, right? But for this question, I'm going with D, right? Yeah. It's hard to explain why I chose D over B, but I've just seen D happen, like, be more emphasized compared to B, right? That's why I went with D. Okay. Again, kidney. This feels like another kidney, kidney. This is good. I like kidney. I like not doing kidney. Okay, so 30-year-old African American guy brought to the ER, swelling around his ankle, confusion past 2 hours. Again, super high blood pressure, pitting edema, visual field disturbances, right? So there is this thing called a hypertensive emergency. This is when you have high BP plus end organ damage. Jesus. Okay. Let me. End organ damage. Okay. And you have hypertensive urgency. This is when you have high blood pressure but no damage. So this case we have damage. That means we gotta do something really fast. Okay, again, goes back to hyperplastic arteriosclerosis that looks like onion, right? Onion skin. So the other one is hyaline arteriosclerosis. This kind of looks like, if this is a vessel, it's like, well, let me draw it a little bigger. But this looks like, if this is a vessel, and usually there's like cells here, and the rest of it is open, right? When you have this thing, there is like eosinophilic. So first of all, the vessel is much tighter, and there's like pink stuff without nuclei all over it, like in the through the thickness. When you have pink stuff without nuclei, it kind of looks like the fibrinoid necrosis. So it's fibrinoid necrosis, or known as, hy- hyaline arteriosclerosis. This is like, um, basically dead proteins, and in case of hyaline, glycosylated stuff, because it happens with diabetes. All right, this sounds like renal. Renal again. No, but so the gene I mentioned earlier in this video, there's a gene that causes mutation in, it's involved in the clear cell cancer or renal cell carcinoma. This is a gene. I don't know why I forgot it. There's actually another gene too. This is not the one that I was thinking of, but this is one of them. Wilms tumor gene. 25-year-old. Actually, this is also renal. Yes, renal. So as you can see, it's pretty renal heavy, but cardio is a more important system in general, and also on exams. So take that as you will. Okay, sounds like to be a cardiovascular question. Got a 10-year-old. I already know what this question is gonna be about. Eats a hamburger, gets bloody diarrhea, right? And then has pain, and then you get conjunctival pallor. It looks like just like paleness, basically. Purpuric rash, and you're like, okay, this is more than diarrhea then. On his lower limbs, like urinalysis reveals proteinuria, hematuria. So you're like, oh shit, the kidneys are involved now. Peripheral blood smear shows schistocytes. So this is, I've said this a billion times, but it's super important. This is microangiopathic hemolytic anemia, right? Micro, small, angiopathic, problems in the vessels, the small vessels. Hemolytic anemia, the blood is getting lysed, and that's leading to anemia. Okay, so basically what happens is that this bacteria has a toxin that damages the vessels. When it damages the vessels, the vessels become hypercoagulable, meaning like they get better at activating platelets. So they start activating platelets. So the platelets start binding to it. These are tiny vessels too. So if this is a RBC, this is like inside a vessel we were talking about. So these platelets start binding to it, right? They're starting creating these obstacles, and when RBCs go through these, they kind of like get cut in half, and they create these helmet cells that are known as schistocytes, right? It literally looks like a half a cell, and there's like some stuff like on the sides like this. So if you see this on a blood smear, the answer is going to be about this, right? That's the diagnosis. You already know, whatever reason, things are your RBCs are breaking down in your small vessels. Now, two things that come to my mind at the moment can cause this. One of them is HUS, hemolytic uremic syndrome. It